Okay, we're back, and I'm going to start this time. We already talked about bladder infections, UTIs, cystitis, and we talked about acute pyelonephritis and where it is, which basically is like the center of the kidney. So now we're going to talk about how acute pyelonephritis can actually end up being chronic pyelonephritis. And here it is, definition: persistent or recurring episode of acute pyelonephritis leading to the scarring of the kidney. So it wasn't able to be cleared with antimicrobials or antibiotics, and now it has scarred part of the kidney. And you can read here: result from thickening of the calyces and post-inflammatory fibrosis with permanent renal tissue scarring. It's more common with obstructions, if there's a urinary anomaly, there's something, structurally is not right, and the vesicoureteral urine reflux, meaning urine is only supposed to stream forward and out. It's not supposed to go back in this system. Or the reflux of urine occurs at the junction where the ureter connects to the bladder. Reflux means it goes backwards. So risk factors for this would be women over 65 years of age, and we talked about that with the estrogen depletion, can cause atrophying of the whole area. Older men with prostate problems, chronic urinary stone disorders, spinal cord injuries, they're probably not going to be emptying their bladder as you or I would. Pregnancy, there's a lot of vascularization around the pelvis area when somebody's pregnant. And because as the uterus gets bigger and bigger, it pushes the bladder out of the way. And in doing that, sometimes we have stasis of urine, or it's not able to be emptied like it should be. Any congenital malformations, bladder tumors, and then any chronic illness is going to interfere with circulation. As you can see, chronic cystitis would be bladder, but diabetes, hypertension, they're circulatory disorders. Its cause may be bacterial, metastatic, or urogenous, meaning from the urine area. Disease is most common in patients who are predisposed to recurrent acute pyelonephritis, such as those with urinary obstructions or, again, like it said, vesicoureteral reflux. Patients, some of the research states with chronic pyelonephritis may have history of bedwetting as a child. Interesting. Diagnosis: how are they going to diagnose any of this? They're going to look at a urinalysis and culture it. Pus in the urine, leukocytes singly in clumps and casts, and a few red blood cells. Significant bacteria in there, significant. Urine culture will show more than 100,000 organisms per microliter of urine. A low specific gravity because it's very cloudy. A slightly alkaline urine pH. Remember, we want it to be acidic. On a CT scan, computerized tomography scan, it can rule out cyst tumors or calculi as kidney stones. In urosepsis with our elderly, they'll have an extremely high white count with a differential to see if the CRP, which is a C-reactive protein, will be very high. CRP usually indicates an infection, so that will be high. They'll have a low specific gravity because they have a decreased ability to concentrate the urine. And again, the urine pH is a decreased ability to concentrate urine, the more alkaline it gets. Treatment, and these are, a lot of our sulfates that we talked about. Sulfonamides are Bactrim and Septra, but also our fluoroquinolones with Cipro, very, very strong drug, and then nitrofurantoin or macrobid. Urinary analgesic, I already said, with the pyridium is kind of anesthetic to the bladder and analgesic, but it will turn the urine orange. So we have to make sure that we tell patients that, so they don't think, oh my God, something now is really even more wrong than it was before I went in. If the infection is caused by an obstruction or the reflux, antibiotics may be less effective because we've got something anatomically in the way. May have to remove the obstruction by surgery, and chronic pyelonephritis usually requires very long-term follow-up because we don't want the kidney to be any more damaged than it already is. Okay, I wanted to talk about the current or flow of blood versus urine in the kidney. Fluid flows in opposite directions through parallel tubes up and down, sides, up and down parallel sides of the loops of Henle. The kidneys concentrate urine through the counter current exchange system. A concentration gradient causes fluid exchange. The longer the loop, the greater the concentration gradient. It's a three-step process. Through glomerular filtration, the glomeruli filter blood flowing through them to form the filtrate. Tubular reabsorption, the tubules reabsorb the filtering fluid in surrounding blood vessel. And then the third is the tubular secretion. The filtered substance, or the glomerular filtrate, passes through the tubes to the collecting tubes and ducts. Understanding it then is the rate at which the glomerular filter blood is normal GFR, which is the glomerular filtration rate, is about 120 cc's a minute. Most accurate measurement is the creatinine clearance. Creatinine is filtered by the glomeruli but not reabsorbed by the tubules. So if it's not cleared enough, we know that there's a problem. That's why they call it creatinine clearance, because it's not reabsorbed by the tubes. So if it's not reabsorbed, it needs to be cleared. GFR depends on permeability of the capillary walls. Are they intact? The vascular pressure and our filtration pressure. If tubules neither absorb nor secrete the substance, creatinine, the clearance is equal to the GFR. If the tubules reabsorb the substance, clearance is less than the GFR. If the tubules secrete the substance, the clearance exceeds the GFR. If the tubules reabsorb and secrete the substance, clearance may be less than, equal to, or greater than the GFR. So we don't want to saturate the system. The amount of substance that's reabsorbed or secreted depends on the substance's maximum tubular transport capacity. The maximum amount of a substance that can be reabsorbed or secreted in 1 minute without saturating the renal system. An example here, to give an example, would be in diabetes mellitus, that's our sugar diabetes. Excess glucose in the blood overwhelms the renal tubules because we know blood's filtering through there, and it causes glucose to appear in the urine because it overwhelms it. It's too much. It's not supposed to be in the blood or the urine. But because the pancreas is sick, it's not putting the glucose into the cell where it's supposed to be, because we don't have any insulin or a lack of insulin. When glomeruli are damaged, protein appears in the urine because the large protein molecules pass into the urine instead of being reabsorbed. Okay. And one of the key concepts here would be too little, too late. In a patient who has renal atrophy from disease, from some other circulatory disease, healthy nephrons enlarge to compensate. There's that word again, compensate. So the nephrons, which are the nerves that send messages to this glomerular filtration unit, enlarge the nephrons, the working areas of the kidney, enlarge to compensate. I'm sorry, not nerves. Forget I just said that. I'm exhausted. The nephrons, the part of the kidney that the blood is going to go through, enlarge to compensate. As damage progresses, the enlargement can no longer adequately compensate. So they can only get so large and they're not compensating. And then the GFR, which is the glomerular filtration rate, is not filtering like it's supposed to, so it slows down. And so with that in mind, now that we know what the glomeruli do, if what I made did not make sense to you, open your book and I would go to the chapter prior to the renal chapter on dysfunction, the one that just talks about the regular anatomy and physiology of the kidney, and study what the glomerulus is supposed to do, because you won't know when it's damaged if you don't know what it is supposed to do. So disorders that directly affect the glomeruli, urinary sediment changes, nephrotic sediment, massive amounts of protein, because as we said here, is that, here, where is it? I'm going the wrong way. Nephrotic sediment, we have massive amounts of proteins and lipids. No, it was, where was it? Here it is. When glomeruli are damaged, protein appears in the urine because the large protein molecules pass into the urine instead of being reabsorbed. So because we have glomeruli damage. And that's why they're saying nephrotic sediment with massive amounts of proteins and lipids, and then nephritic sediment with casts and proteins. And then just again, a little bit of a review. Glomeruli are many capillaries that loop into the Bowman's capsule. They look like fingers, and together they make up that renal corpuscle. The glomerular filtration membrane filters blood components through its 3 layers. It's surrounded by Bowman's capsule and the nephrons of the vertebrate kidney. It receives its blood supply from an afferent arteriole of the renal circulation. Unlike most other capillary beds, the glomerulus drains into an efferent arteriole rather than a venule. The resistance of the arterioles results in high pressure in the glomerulus, aiding the process of ultrafiltration, where fluids and soluble materials in the blood are forced out of the capillaries into the Bowman's capsule. Okay. So glomerular disease demonstrates a sudden or insidious onset of hypertension, edema, and a sudden increase in a BUN, blood urea nitrogen. Hypertension because we are overtaxing the entire circulatory system, and it's not filtering the water like it should, so it starts third spacing into the interstitial fluid. That's why we get edema, and we have a sudden increase in blood urea and nitrogen, because that is all, not so much the blood, but the urea and nitrogen are poisons. They're supposed to be voided. They're supposed to go away, and they're not. And so the BUN starts to climb, and that is one of those labs that is specifically for kidney function. Decreased glomerular filtration rate, we have an elevated plasma creatinine, urea, and reduced creatinine clearance because it's not clearing it like it's supposed to. Glomerular damage causes a decreased glomerular membrane surface area, glomerular capillary blood flow, and blood hydrostatic pressure. Plasma proteins leak out of the capillaries and are excreted into the urine, resulting in hypoalbuminemia. It encourages plasma fluid to move into the interstitial spaces, and there's our edema. In nearly all types of glomerulonephritis, the epithelial layer of the glomerular membrane is disturbed. Okay, I'm going to go ahead and stop here, and we'll go on with the glomerular disorders in video 3.